And Impella also led to increased survival. So the more you revascularize, the biggest advantage of Impella is that you can complete your revascularization. Otherwise, when we have patients with high risk PCI or we have patients with MI with cardiogenic shock, we tend to open the culprit vessel and leave the rest, or we stage our complex PCIs. And that is leads to generally worse outcomes than completing the revascularization. So MCS allows us to complete the revascularization, and with now beautiful technologies like intravascular ultrasound available, you can minimize your contrast use, and at times you can use zero contrast to finish your whole PCI. And the renal function, which is a very important thing, with MCS, your renal function actually improves. So you'll notice that patients who have come to you with a creat of 2, 2.5, GFR of 39, 38, 37, they manage to come down to a creat of 1.5 because effectively you're creating more perfusion for all the organs, not only the coronaries. So MCS is definitely good for all of these patients. So it increases all-cause death, reduces all-cause death. One stage is always better. On-pump protected PCI is definitely better than doing non-protected PCI. Extensive revascularization with Impella in high-risk patients is definitely beneficial, and especially more beneficial in cardiogenic shock. Protect 2 showed that 47% reduction in post-discharge MACE events and continuous safety. So initial issues with Impella was we were not used to large bore excesses. Now with more and more experience, our bleeding rates start going down, and our complication due to the device itself starts going down. Of course, we have to keep watching for hemolysis. We are going to use it for long term. We have to keep watching for complications like right ventricular support, because that's a very important thing when you use an MCS, because the MCS which we use is left ventricular. So sometimes your right may fail too. Then you might have to switch him to a BiVAD or a by both sides Impella. So that's a very important thing to follow. But I thought we won't go into detail how you're going to see these patients post later. Now the guidelines are very clear. Initially, guideline for cardiogenic shock MI, it was class 3 indication. But after the danger shock trial, they found evidence that it was moved to class 2A. So if you have an acute anterior wall MI with cardiogenic shock, it's a class 2 indication to revascularize with mechanical circulatory support. And there is definite evidence that this is going to be beneficial. So the key takeaways from here is that heart team approach is a must in CHIP cases. CABG is always an option, but at 93, I don't think anybody would want to open a chest of a 93-year-old person. Impella-assisted PCI is safer in such cases. Detailed evaluation in the form of imaging is always useful for long-term outcomes. Since you are going into a complex procedure, might as well image and see what you're doing so that you don't have to come in again. Be ready for surprises, as we were in the femoral part, and be innovative. Before I end, I'm going to show you another case which we did. It's an interesting scenario. We had a doctor. He was an 87-year-old doctor. He had severe aortic stenosis. He presented with acute coronary syndrome with an EF of 25%. And again, the same thing, he wanted everything done for him. And we were caught in quandary, what do we do first? Because his EF was down because of his aortic stenosis. It was down because of his severe coronary artery disease. And so we were thinking, should we just do coronary artery disease? But I said, if you do coronary artery disease alone, without opening the aortic valve, he may not take the compromise. So then we thought, let's do TAVI alone. Then we realized if you do TAVI alone, we would have access issues to the coronaries because the coronaries was badly diseased. So if it cannot engage the coronary, we would have been in much bigger trouble. So we did an intermediate thing. So what we did, we put all the material for a TAVI. We put a wire across the LV. We ballooned the aortic valve, removed the balloon, put an Impella. We put an Impella after ballooning the aortic valve. We finished the coronary. After finishing the coronary, we re-put the pigtail, removed the Impella, and did the TAVI all in one sitting. He's still alive and doing very well. So he was 87 actually. And this is his EF. Very, very bad, high gradient, calcified triple vessel disease. And this was his CT analysis in the Trementio. And these are his peripheral vessels. As expected, not the best, but not too bad. So we did a pre-dilatation. We put the Impella. We did angioplasty to the LAD and circumflex. Then we put a 27.5 millimeter Y valve. We deployed the valve, and we had a good result. So we finally revascularized both together for him, and he's still doing well. Thank you very much.